Today, White Army is proud and grateful to have Dr. Akash HS as our mentor. Dr. Akash HS as an MS in Orthopedics, DND MRCS Glasgow, DIP CCOT Belgium, PNB in FNB in Spine Surgery, Department of Neuroscience, Sakra World Health Hospital, Bengaluru. Sir, could you please start with the presentation?
Yeah, thank you. Thank you for the introduction. And I thank the White Army and Kishan for giving me an opportunity to share some information what I have with the participants here. So to begin with, like I'll be presenting few scenarios along with the basic outline of management, how to manage a trauma case. So here, okay, a disclaimer here. For actual protocol-based management, I suggest everyone to attend the ATLS course. This presentation is only for the undergraduates and with few practical points. Okay, so why trauma management is very important in a present scenario? Because most of the cases having any injury, like maybe a head injury, chest injury, or spine, or any long bone fractures. So these are the population of patients who are between 15 to 45, 50 years. They are the active bread earners of their family and young patients. So we'll have to give a very good outcome for them. So to begin with, any patient who walks into your casualty, we'll have to initially triage them, whether it's an immediate, urgent, or delayed. I think this everyone will be familiar with. With Indian scenarios, with limited facilities and resources, we should be very careful in handling what we can do and what cannot do, so that we can refer to the higher center for a good outcome. So this triage chart, I think everyone will be familiar. So any assessment, a patient coming to a casualty will be a primary survey and a secondary survey. Primary survey, based on the ATLS guidelines, it will be ABCD, like airway, breathing, circulation, and disability, followed by exposure. So this primary survey should happen very quick, maybe less than 1 or 2 minutes. Like with few experience, you will be able to do it. Followed by, don't concentrate much on the history, just basic history to know the velocity of injury, what happened, was he under any influence of any alcohol or any medication. All these things should be quickly asked in the primary survey. A detailed secondary survey, that time you can get back to the history, like when, where, what, how the injury happened. So in primary survey, we have got airway maintenance and cervical spine protection. Most of the patients, very less incident, less patients come with the unconscious state, but most they'll be able to talk. If someone can complete a sentence in their mother, it means that his airway is maintained. He is able to breathe properly, and there are no facial injuries or no maxillary injuries and no jaw fractures and no tracheal injuries. Are the these are the things what you can assess just if a patient is able to talk. Just ask him how did the injury happen, and along with that, if patient is conscious, then just ask him to lift the neck and lie back. If he is able to do and there is no neck tenderness, neck pain or neck tenderness, we can clear that the spine, cervical spine is not injured. In case if the patient is unconscious, then definitely it's tough to rule out a spine injury. So considering if he is unconscious, make sure you immobilize the cervical spine with a Philadelphia collar, and suspecting there is a cervical spine injury. Next, followed by breathing and ventilation to assess whether there is any chest injury, rib fracture, or bruising around the chest. To that will be checked with a probe. And circulation, you will be checking the blood pressure along with the peripheral pulse. Both, like in case if it is just a closed injury, then you'll have to check in the upper limb, and along with that, the limb which is involved. If there is a open injury or a closed injury, lower limb, definitely you will have to palpate for both dorsalis pedis and the posterior tibia. Followed by these things, you'll have to do the disability assessment, like motor examination, sensory examination. This will be coming in the secondary survey, but initially definitely you'll have to check for the Glasgow Coma Scale. I think everyone is aware about those things. Followed by the exposure to examine the other parts. So initial stabilization will be ABC, airway, breathing, and circulation. So this is how algorithm goes. Once a patient comes to the resuscitation, first you will be doing the triage, the one in the red tag. Then definitely they'll be assessed for airway, breathing, and circulation with the primary survey. Once the airway, breathing are stabilized and patient is stable with fluid and other resuscitation management, then the other steps like the disability assessment and exposure to check for other factors will be conducted along with the necessary radiological investigation. So here a very important clinical aspect will be what IV line do you insert in a patient with a who will be presenting in a shock. Can Vaishnavi answer, please? What color of the IV cannula will you use, madam? Vaishnavi, are you there?
So I don't think she has unmuted for the session, sir.
Okay.
But
Chaitanya?
could you please unmute yourself?
Chaitanya? Okay, I don't want anyone to leave just because I'll be asking questions. So, okay, not a problem. So the most commonly in any polytrauma
Folks, dressing has replied as green 18.
Okay. Yeah, that's true. Thank you. So patients with a trauma like this, any RTA or any trauma, they'll be usually presenting with a hypovolemic shock. So hypovolemic shock will be present with the hypotension, low BP, like less than 100 by 60, and tachycardia, the heart rate more than 100, cool, pale, moist skin, and decreased urine output. If there is a spinal injury and the neurogenic shock, there is a discrepancy. Though they have a hypotension, there won't be a tachycardia in case of a neurogenic shock. It will be a bradycardia. You should be aware about this situation also. So in hypovolemic shock, we have got different stages, stage 1 to 4. If the blood loss is less than 750 ml, then it will be coming in the stage 1. The pulse rate will also be not high, it will be less than 100. Just mild or normal to increased pulse pressure may be there, but BP there may be slight reduction. Urine output, everything will be good. So only management with a crystalloid, like preferably ringer lactate, which is almost near isotonic to our blood plasma. So that is sufficient. But in case if there is a long bone fracture or a open injury or a pelvic fracture, there will be blood loss more than 2000. So here we'll be requiring crystalloids initially to resuscitate, followed by blood products. Like now the present recommendations will be segregated, like PRBCs and platelets and plasma, like not a whole blood. It will be separated blood products will be advised. So definitely there will be a increased respiratory rate and urine output will be negligible. Normal urine output will be 0.5 ml per kg body weight. Okay. So the CNS mental examination will also be confused and lethargic in case of a high volume loss hemorrhagic shock. So fluids, as mentioned, ringer lactate up to 1.5, like 3 pints of fluids maximum 4 can be tried. In case even if the BP is not picking up and the HB is falling low, then definitely you'll be shifting to a blood products. Okay. In case if you notice active bleed in a limb injury, so you'll have to initially plan with a try with a compression bandage. Even if the compression bandage is getting soaked, then you try a tourniquet. Tourniquet may not be available everywhere. So even if the BP apparatus is handy, so just apply a BP cuff and inflate. In upper limb, more than the based on the systolic pressure, 60 mm higher than the systolic can be gone. Like if the BP is 100, you can go up to 160. Maximum 1 hour, you can keep the pressure. Then again, you will have to deflate. In the lower limb, double the systolic you can go. So if 100, you can go up to 180 to 200. There, 1.5 hours is the maximum time which you get to find a source of bleeding and ligate it. That's how it is. So as mentioned by our friend here, you are perfectly right. Green cannula. At minimum, 2 cannulas should be secured, and the cannula should be secured as early as possible, because all of us know about the golden hour, the first 1 hour of the trauma, which is the maximum time, best time what we get to get the best outcome of the trauma patient. So why we advise a green cannula? Because green or above, like 16 or 18, 18 is green, 16 is gray. 16 ml size cannula will be able to infuse 80 ml of fluids per minute. This is very good. So this is actually required in a resuscitation. So at 2 cannulas should be secured, and a main wide bore cannula should be inserted in a larger diameter veins, like in the elbow, not just in the periphery, in the wrist or the dorsum of hand. So to have a few scenarios, I'll be glad if someone can answer here. So we have got 5 participants. Chaitanya, are you there? Can you unmute yourself? Gaurish, Vaishnavi, anyone? Nandini, or else you can also join.
Yes, I'm here.
So can you explain what has happened here in this scenario?
So it looks like a traumatic fracture.
Okay. You are in 3rd year, right?
Yes, sir.
Orthopedics postings done?
No, sir.
Okay.
Fourth.
Okay, sorry. So this is a case scenario of a open injury. You can see out the distal part of the femur with the open injury over the anterior part of the patella. So in these scenarios, we should know any femur fracture, there will be blood loss around 1000 to 1500 ml. So he'll be presenting with a hypotension and tachycardia, low BP with active bleeding. So here, immediately once you see a projected bone outside, you are not supposed to reduce this, because there is high chance of contamination and later patient having a infection. So you should give a thorough wound wash. First, resuscitate the patient, check for the ABC, chest compression, pelvic compression, and give adequate fluids and the tetanus dose, because you don't know what was his status of prophylaxis before, and antibiotics. Just if it is a type 1, like I'll mention, there is a Gustilo-Anderson classification is there. It is especially useful for orthopedic practice. As per the open wound, this is a type 3 type of Gustilo-Anderson. So in these cases, they'll definitely need a antibiotic prophylaxis. Cephalosporin, group 1 or group 2, along with the gentamicin or amikacin. If there is a farm contamination or a anaerobic contamination, like falling in a gutter or something, then they'll need a metrogel for anaerobes. So along with this, his GCS has to be measured, and never attempt suturing all these open wounds unless you have done a proper wound wash. At least they tell 4 to 6 liters of fluids to be used to irrigate and clean the wound. There's one more scenario here, a open injury on the palmar aspect of the wound. Chaitanya, can you just tell what will you check for in this patient? You have done the EPC. Anything else you want to check here? Someone has mentioned that they are unable to unmute. Can you just?
Yes, sir. So we should check radial artery pulsations.
Yeah, that's true. So peripheral pulses, only radial artery you check or anything else? So always go with the radial artery along with the ulnar artery. Check for capillary refill in all the 5 tips of the fingers. Then check for the neurological status like ulnar nerve and median nerve, just if they are able to move the hand. Any open injuries, initially they should be stabilized. Getting an X-ray is not a primordial factor. Once you patient is resuscitated, then you can go for an X-ray. So this is how this patient presented with an open injury with a comminuted distal and radius and ulnar fracture. So based on this, we went with a further management, debrided the wound, gave the antibiotic prophylaxis, then applied an external fixator. So this is one more scenario. Patient presented with we tell it as a Gustl-Anderson 1, type 1 if it is less than 1 centimeter, type 2 if it is more than 1 centimeter, less than 10 centimeters, and type 3 if it is more than 10 centimeters. So all these comminuted fractures, initially they should be debrided and splinted. Like either it can be a external splint like a slab or a Thomas splint or any other hard rigid objects, then or an external fixator. Open injuries need not be always immediately managed with a definitive fixation. In upper limbs we do a definitive fixation like plating or wire fixation, but in lower limbs preferably, because we don't know how much is the intensity of trauma, how much is the soft tissue damage that has happened. In cases if you feel there is a contamination during the debridement, you have to extend the incision and then go for a debridement. So this is one more scenario where patient presented with a comminuted distal femur fracture with an open injury. So the best time to do a articular reconstruction will be the initial first stage of debridement, because the fragments will be very mobile and you have an access to the fracture site. So this is how it appears after a thorough debridement and articular reconstruction. This is called articular reconstruction, then a closure along with an external fixator. So always it should be closed with a drain, so not to allow any blood collection within. Our motto should be, in any open fracture, first saving life, then saving the limb. Concentrate mostly on the central parameters like systemic parameters like airway, breathing and circulation, than look into the limb. Even limb is important, but give more preference to the systemic issues. So in case of a proximal tibia or around the elbow fractures in pediatric, chances of having a compartment is very high. I assume that all of you are aware about the compartment: shining skin, tenderness, like pain out of proportion, and many other factors which you have to be looked, along with the pulsation. Check for the pulses and the neurovascular deficits. Scenarios. Just so far I had just described about the upper limb or the lower limb long bone fractures. Can anyone tell what are these, the yellow boards? Gaurish, can you tell what these are?
Sir, to support the limbs at trauma site.
Okay, yellow ones. Okay. Yeah, these are called the spine boards. These are actually spine boards. The advantage of these spine boards are you'll be able to shift the patient from one trolley to the bed or for any other radiological investigation. And even in case of a long bone fracture, you can use it because we don't want much of a mobility in the limbs. Okay, because it will be very painful. And other advantage will be these will be radio lucent. So even in X-ray, there won't be any obstruction. You can get a X-ray keeping the patient on the spine board. So usually these are used in the cervical spine or the thoracolumbar fractures in the spine particularly. Even in the long ones you can use. The other one, this is the Thomas splint. So usually used in the immobilization of the lower limbs. So upper limbs can be immobilized tentatively, temporarily with the slabs. So any fracture, the slab should be applied one joint below and one joint above. So if you have got a forearm fracture, so go up to the above elbow slab and don't ever attempt applying a cast in case of an acute injury, because there is always a chance of swelling increasing and resulting in a compartment. So this is a scenario of a patient who presented traveling on a bike. The most common injuries will happen to the pillion rider, not the one who's driving the bike. So the one who's sitting. So this is an L3 fracture. You can see the retropulsion of fracture fragment into the canal. So anterior 1/3 splaying, decreased foraminal height may not be that relevant for your undergraduates. And here in the AP view, you can see the increased interpedicular distance. These are the features of a burst fracture. So once the patient is stabilized, then they'll need a CT scan if there is a burst fracture in spine, or a CT scan of the joints in case if there is an intra-articular extension. So this is how we went ahead with the CT scan. There was a flaying of the fragments with combination body height reduction more than 50%. Then definitely if there is a neurological injury, complete neurological injury, more than that, an incomplete injury should be given more preference, because there's a high chance of recovery if you manage the incomplete neurodeficits. So this was an MRI of the same patient. We can see the posterior fragment indenting on the spinal cord. So she was managed with the stabilization. Anteriorly, a cage was placed with the posterior stabilization. I got one more similar patient. Neurology will be explained a trauma case in the score of Asia. Asia A means complete neurological deficit, no sensory, no motor. Asia E means there is a intact neurology. So say a similar patient, Asia A neurology, you can see the kyphosis, more than 50% of collapse with compression over the cord, and CT also showed the same fragments in the canal, and she was managed with the posterior stabilization. So briefly, this is a video to check a quick examination of the limbs once the resuscitation is done. So I thank our colleague, Dr. Mr. Radhe, and one more Dr. Mr. Suresh. Okay, Nandini, are you able to hear the audio?
No, sir, we are not able to hear the audio.
Or is it? Okay.
Yeah. I think you have to increase the volume, sir.
Okay, no problem. Oh, sorry. So to examine a quick examination after resuscitation, like ABC, to check whether there is any long bone fracture, or we'll have to do a chest compression and a pelvic compression and check for upper limb fractures or a lower limb fracture. If patient is unconscious, definitely you should think that there is a spine injury, and you should be more relying on your clinical skills like crepitus, abnormal mobility, all those things should be looked into. Okay. So here, sorry. So here, I'm asking the patient to lift the limb to rule out any neck injury, and I should initially ask for whether there is a pain in the neck. If the pain is there, is it manageable or intolerable? So if patient can tolerate, then if he can do this much, you can rule out the cervical spine injury. So followed by that, so we should do a examination of the clavicles, because among the injuries, clavicle is the most common bone fracture that can happen. So then followed by a chest compression, because patients having a clavicle fracture can present with a chest injury like rib fractures. And with this maneuver, pressing on the chest both from the sides, you can elicit any tenderness or any bony crepitus to rule out any blunt chest injury. So followed by, you'll have to do a pelvic compression test. This is to rule out, because all the patients, any trauma patient, they'll be coming on a trolley. They may not be able to, may not be in a state to walk. So we'll have to rule out any pelvic fracture, because patient will be in hypotension. So pelvic compression test from the sides, and this is a distraction maneuver to check for the posterior sacrospinal ligaments, like distraction injury. And always check for the range of movements in all the joints, shoulder, elbow, to rule out any long bone fractures or unrecognized, unnoticed fractures. Lower limb also, flex, extend. Just make sure there are no obvious fractures, because these are to rule out subtle injuries you'll have to do to clear a trauma case. So there is a method to shift the patient log roll to examine the back. We need at least 3 people to turn a patient who is unconscious and there is a spine injury. 1 to stabilize the neck. So hold the neck, support it, not to allow any movement, and later followed by that 1% stabilization, fold the hip joint and the knee joint, and one should hold at the chest and other should hold at the pelvis. In synchronization, they should rotate. Okay, so then you can do, okay, then you can check for the tenderness in the spine, to rule out any other spinal vertebral injuries or any bruises or any contusions as a part of clearing examination. So okay, that's how you do a log rolling. 3 people are required. And so I want to mention a few things here. So there are most of the patients responds for a fluid resuscitation with a 2 to 3 units of ringer lactate. They'll be maintaining a good BP, and once you stop the coagulate or ligate or control the bleeding in the open injuries, they'll improve. The hemodynamic status will improve. If even after 4 pints of fluids, if patient is not responding, then they are called non-responders. Then definitely they'll need a blood product transfusion. So if the GCS goes below the 7 or 8, definitely they'll need a intubation. And in case there are certain bleedings where if you ligate or suture, the bleeding will definitely stop. In example, like the scalp injuries, patient will be bleeding profusely. So once you clean the area, you give a local infiltration, and you can suture with the 2,0 ethylon, a non-absorbable suture material. 2,0 mattress can be used. for the scalp. So facial injuries, don't go with the high size of suture material. Go with 30 or 40. Use a Prolane, or a Vicryl won't be that strong in a smaller sizes like 30, 40. So ask for some help, like a senior person who can suture very nicely, so that they won't have a very bad scar. So to know the urine output, any trauma patient should be catheterized and IV line should be secured. IV line 18 gauge, catheter better to go with the 14 French Foley's catheter will be good. So just to know the urine output and to monitor the input output. So in case still if the patient is not his BP is not picking, then you can try limb elevation, then followed by foot and elevation also. So other than these clinical aspects, so I would like to mention few things. In any case scenarios like this or trauma, lot of medico-legal aspects come in. So you should always document properly the date of injury, time of injury, and who brought the patient, and whether it was a two-wheeler versus two-wheeler or two-wheeler versus four-wheeler accident. These two things to be very properly documented. First, concentrate on the resuscitation. Followed by that, you can go with the documentation. In Indian scenario, when RTA case patient will be followed by a lot of relatives. So don't try to explain the condition to all the relatives. Just choose like the one who is very, you feel you are safe and is understanding. That patient, that one relative should be explained all the course of the event and the management, what you're going to do, and make sure you stay away from them and you are able to concentrate on your work. So there is something called a fast scan. After the primary assessment, even if the BP is not picking up, then you should check for any other internal bleed that's happening. Usually that can happen is a pericardial effusion or a retroperitoneal bleed. FAST is a syncronym of focused assessment of sonography in trauma. So they keep the probe in 4 different places, one in the pelvis, one in the epigastrium, and one on the either flanks, to check for the splenic and hepatorenal areas. So with all these interventions, you should make sure you maintain the patient in euthermia. Like patient should not go for a hypothermia, because you are resuscitating with so much of fluids and the blood will be stored in a cold storage. Hypothermia increases the chance of coagulability, like blood clotting will be more. So when you secure an IV cannula, make sure you send a basic investigation of blood test. Majorly will be a complete hemogram and blood grouping and typing. Okay, because blood grouping, it will take minimum 2 to 3 hours, or means at least 1.5 to 2 hours to have a cross matching and getting a blood. So any polytrauma patients, like if more than 2 to 3 systems are involved, then once you secure the IV line, make sure you send the sample for a basic blood test, CBC, serology, and blood grouping and typing. Make sure you are using all the universal precautions. Wear glove. Consider everyone as a positive patient unless proved otherwise, because you should not be at any risk. So X-rays, the basic X-rays, one after resuscitation will be the chest X-ray to rule out chest injuries, pelvic X-ray, along with cervical spinous. If patient is conscious and oriented and able to move the neck comfortably, then no need for a neck X-ray. Otherwise, these two, the basic X-ray, are followed by the limb X-rays. Whichever limb there is a fracture, you should get an X-ray of one joint above and one joint below. So with this, I think I'll be concluding my discussion in this forum. Anyone has any doubts, please, I'll be glad to answer you.
So how to manage fat embolism in trauma, sir? Like
Okay,
long bone fracture.
Okay, fat embolism happens usually in the long bone fractures, like femur. So there is a few gradings and a few criteria which has to be looked into: petechial rashes, hypoperfusion, and low drop in saturation. So fat embolism mostly require a closed monitoring and an ICU setup. So usually they'll be giving you'll need to give a good resuscitation with fluids, and saturation has to be monitored continuously. Always about fat embolism, that has to be explained to the patient and the relatives, because anyone with a long bone fracture, maybe on day 2 or day 3, they can have just a quick embolism and drop in saturation. If you give a good oxygen support, like with 4 liters, 6 liters based on the demand, you'll be able to overcome the fat embolism. Anything else?
So there's actually a doubt on YouTube. May I read it out?
Yeah, please tell.
Yes, sir. Just one second. This one YouTuber has commented, I have long going problems with pelvic floor and psoas. They separated the costochondrial area. Nobody seems to want to help me. Do you have any advice? I pasted the question onto the chat section, sir.
Okay, I'm unable to see that. Madam, can you repeat the question? What is it?
So just one second, I'll paste it again. Now, sir.
Yeah, I have a long going problem, pelvic floor, psoas, and separated costochondrial area, nobism. Okay, this may not be relevant to this topic. You can message him that he can mail me, or message me. I'll be able to answer him separately.
So there's another question from Nikhil Vasudeva. He says,
Okay.
Sir, please explain Hertel criteria.
Okay, just a minute. Okay, Hertel criteria. Why is it? Okay, may not be like today we'll be limiting ourselves to trauma discussion. Okay, this is very particular for a humerus fracture. Nikhil, I'll just text you later. Is that okay? Okay. Sir, how to take consent from patient relative real life? So yeah, consent is very important even for a blood transfusion or any other procedures which you are going. Even a simple suturing, you will have to definitely explain what are the pros and cons, and in their own understanding language, and make sure you take at least 2 people's signature. The important aspect here is you should not attempt any procedure patient sitting or standing. Even an IM injection or an IV clearing a cannula, everything has to be done on a supine position, because we don't know what is their pain threshold. Anytime they can have a vasovagal attack. So consent, while taking consent, this is not taught much in our Indian system of medicine. When you do a like a MRCS or any other course, taking consent is one of the examination table discussion. So make sure they're comfortable. You explain all the procedures to the relatives and gain their confidence. Then you can go for the signatures, not just like randomly just asking them to sign. And always one person should be a point of contact with the relatives. Every time every other person, like different people go, they get annoyed and information is not conveyed to them. So that is not how it goes. So one person should be able to manage a patient like in that scenario. Gaurish, was that what you wanted to know?
Gaurish, you can unmute yourself or you can use the chat section.
Yes, sir. Yes, sir.
Okay, Gaurish.
Sir, one more thing, sir.
Yeah.
Like, how to ask the patients how to take the sorry. One more, anything for undergraduates to learn from your real life experience, like anything mistakes,
Consent.
anything that
Consent.
happened in your real life. Yeah.
Oh, consent. What happens is usually what will happen when there is a trauma, lot of relatives will come, but the actual close blood relatives won't be there, because in the day 2 or day 3, the one who has signed won't be there with the patient. Someone else will come. So make sure the close relatives like brother, sister, parents, or whoever is going to stay for a longer duration with the patient, his signature has to be taken. These are a few things what I have seen. If it is an acute injury, like a major injury, if no relatives are there, then the treating doctor for the patient benefit, you can take you can signature yourself and along with your friend and go ahead with the procedure. That is also there. There are few scenarios where you can go ahead without the patient's consent, but make sure always they are informed. Okay, don't venture into any procedure without a signature.
Okay, sir. Thank you.
So there is another doubt.
Yeah, polytrauma, there are multiple definitions present. Based on a injury to severity score, there is a grading. If it is more than 18, then it is called as a polytrauma. These are vague definition, more than 2 systems. All these are not there. There is a definition. There's a grading called injury severity score. Based on that, there are other sub criteria. If the score is more than 18, then it is called as a polytrauma.
For all the viewers on YouTube, the question that Sir just answered was, what is the current definition of polytrauma and 2 injuries that are greater or equal to 3 on the IAS?
Okay, that's what I mentioned. If injury to severity score, if it is more than 18, then it is called as a polytrauma. Suppose if GCS is equal to 8, not conscious, what will be definition? So there are indication for intubation. So based on the GCS, like if it is below 8, they'll need securing the airway, like in a intubation or a temporary laryngeal mask airway. Those are needed. So just a minute. One point I wanted to mention, in case if you are able to palpate a radial pulse, then it means that the BP is good, like it is more than, definitely more than 80. If you are unable to palpate the radial, then go with the femoral pulse. If you are able to do that, it means that BP is between more than 70. In case if you are unable to do both radial and femoral, it definitely means that it's low BP, systolic less than 70. You should be able to palpate the carotid. If carotid also not there, then it is a sign that the BP is less than even less, that is less than 60 degrees, 60 mmHg.